I will record the session as well. So, welcome everyone for our second monthly meeting. We had published for first monthly meeting. We had published the newsletter, and I hope that all of you got the time to go through it. If anyone has not received or not aware where are the details, please let me know. I can share it again on our chat on our WhatsApp group. And for today's meeting, we will just begin. We have a lot of topics to cover, and these were the initiative we also spoke last time that as part of Cardiac Con Society, what we are doing. So we are actually having the national level conference, which is focusing on cardio diabetes and renal care. Then we are also running the state chapters. We have started initiative to release our monthly newsletter with the help of these meetings, which we are doing as monthly meetings. Then we are already working on conference book. We are also planning for clinical trial in cardio diabetes and nephrology, and we are working on our increasing presence on LinkedIn and Facebook. So I request all of you to please follow our page on LinkedIn and Facebook. I will share the links again over the WhatsApp. So with this, we will just go through the topics which we are going to cover as part of this meeting. So we have around 17 topics which we already shared in the group, and those 17 topics are listed here. So we will start discussion with our very first topic, and with that I will hand over this to Dr. Ashutosh. Dr. Ashutosh, you can start the discussion regarding the first topic, which is FDA approval artificial pancreas for managing type 1 diabetes during pregnancy. Over to you, Dr. Ashutosh.
Hello.
Yeah, we can hear you, sir.
Okay. So I welcome you all again in this evening meeting, and I can see few of our friends have joined, and rest other people hopefully will join. And if by any reason somebody is not able to join the things, they can communicate us on our WhatsApp group, or they can email us to reach out and to us and share their opinion regarding different scientific topic. Last time, Nupur, you have gone for a poll regarding the short listing of the topic. I think that can be routinely done so that we can reduce the topic burden to 17, 18 to at least 6 more significant topics, and we can have a discussion on that, and we can publish all 18 topics depending upon the scenario, and we can have a pre-discussion on the WhatsApp group also.
Sure, I will do that.
Everybody is agreeing on this, or if yes, then this can be done regarding the artificial pancreas and this approval in type in pregnancy. Yeah, the thing is, we have recently learned that the FDA has approved the insulin pump for hybrid insulin pump for the management of the type 1 diabetes during pregnancy, and this is a significant milestone in the diabetes care, and this approval has been based on extensive clinical trial and research demonstrating the system's efficacy and safety. The key point of the FDA approval, the thing I have drafted one summary for this, and I have posted this in the WhatsApp group. And the main point is the system is CAM APS FX, and this is the system which is compatible with the Dexcom G6 and Abbott Lifestyle Libre 3 CGM system, and the approval is mainly based on AIDAPT trial, which has been published in New England Journal Medicine. And because of this AIDAPT trial, which was the 16-week, the trial was used in type 1 diabetes patient, and which has shown a significant difference as compared to the standard therapy. And on the basis of this, since this trial has showing the positive outcome on neonatal and fetal outcome, that's why this has got approval. And this is one of the milestone in the treatment of type 1 diabetes, as this type of therapy is earlier not available. And with the advent of this CAM APS FX system, now we can able to manage the type 1 diabetes in a better manner. So it is open for the discussion. Can anybody want to add anything or wants to highlight anything regarding this artificial pancreas and pregnancy in type 1 diabetes? Or the house is open for the discussion.
Sir, may I just add to what splendid coverage you had? It is
Yes.
basically an app. The app is compatible, as you said, with Dexcom G6 and Abbott Freestyle Libre 3 CGM system. And as you rightly said, it was the basis for endorsing this new app, which is basically algorithm, and it is also working both for type 1 diabetes and aged 2 years and older. Right from that age onwards, pregnancy has been the offshoot of AIDAPT trial. So
Yeah.
automated insulin delivery. So
Yeah.
basically, FDA has authorized CAM APS FX, a closed loop algorithm that links compatible continuous glucose monitors and insulin pumps into an artificial pancreas for patients with type 1 diabetes aged 2 years and older. So that's an add-on that we can share with our esteemed colleagues. Pregnancy is a big deal. I totally agree. And somehow the AIDAPT trial had initiated this trial patients in 16th weeks of gestation onward. So I believe in times to come, it will be probably utilized from day one of established conception for optimal glycemic control.
If you are dealing with the pregnancy in diabetes, you can go with the day one of the inception also. Very, very well said, sir. And point well taken. And it is for the information that it is approved for the 16 week onward. So this is very, very important, as the pre-GDM patients are also becoming very, very important nowadays in the management of the diabetes. So going to the next topic, and that is the I guess we can go to the lanifibranor, the pan PPAR agonist. Another topic I just want to elaborate on that. This is a very, very important topic, and in the background of this, we have to consider that earlier the trial has shown that pan PPAR gamma is associated with some adverse cardiac outcome. Yeah.
Which topic, Dr. Ashutosh? It is not the topic two?
Third one.
Okay.
I'm going for the third one.
Okay, I will just change the slide.
Yeah.
Thanks.
So the thing is, earlier it was seen with the pan PPAR gamma agonist. There were some adverse outcome in terms of cardiac mortality, and earlier, because of these side effects, these drugs were withdrawn from the market. And now again we have come up with the another pan PPAR gamma agonist. And the point is why there is a need of this type of another PPAR gamma agonist, while we have lots of alpha or gamma inhibitor. As we all know, the PPAR gamma isoform contains of alpha, delta, and gamma type, and all these have a different physiological and pathophysiological functions to perform in our body. And it is very, very important to have appropriate inhibition of the PPAR gamma and alpha. Particularly, the attention should be paid to the PPAR gamma, which has got a very good anti-fibrotic activity, and because of this anti-fibrotic activity and the action is
I think something happened with Dr. Ashutosh internet. Let me reach out to him.
Can I add to that?
Yes, please go ahead.
So, from the nice introduction of the new molecule under development, it's a new molecule, lanifibranor, and it is a triple agonist of PPAR alpha, delta, and gamma. So, in preclinical model trials of decompensated cirrhosis, the product has shown marked improvement in fibrosis and portal hypertension. So, based on the established role of PPAR activation that is going around in regulating metabolic processes, the company believes that the product will handsomely address steatosis and other inflammatory markers of the process of cirrhosis. All stages of cirrhosis may be benefited, and ultimately fibrosis may be prevented. And so we are looking at the older term NASH rather than the newer MAFLD, metabolic dysfunction associated liver disease, fatty liver disease. But it's
okay,
still in development stage, yeah.
Yeah. Still in the development phase. The point is the main emphasis came from the Legend trial, in which the combination of this EMPA and this new molecule pan PPR gamma has been tried, and they are looking for the outcome for this, and they have shown they are looking into the primary endpoint and the other points which are favorable in terms of the liver fibrosis. So once the Legend trial, which is a phase 2 trial, the reports are available, then we are able to say something about the efficacy of this molecule. But still, if this molecule has shown some effect on the NAS, then it will be a very important molecule. But nonetheless, till time, it is very, very important that now we have the established molecule, that is the pioglitazone. It should be utilized in the maximum number of the patient, and as the other guideline from the NAS and now MASH is also emphasizing on that. So with the permission, I want to move on the next topic, that is the clinical practice guideline for the NAS. That is the term, the non-alcoholic hepatitis, and now the terms has been changed. But as far as till date, now few guidelines which are available in this area. One is the American Gastroenterological Association AGA guideline, which was released in the September 2021. Another guideline, that is the American Association of Clinical Endocrinology AACC guideline, which was released in the May 2022, and another guideline, that is the American Association of the Study of Liver Disease AASLD guideline, which has been recently released in January 2023, and European Association of Study and Liver guideline, which mainly focuses on the diagnosis, treatment, and follow-up of NAFLD patient. Apart from this, the Asia Pacific guidelines are also available in this area, and recently the NICE guideline has also included a separate section for this, apart from these ASEAN guidelines. So what are the common theme across all these guidelines? First is very, very important that lifestyle modification is the cornerstone of the therapy, and all guideline emphasizes on the lifestyle modification and the weight loss, and losing weight more than 5% and reaching up to the 10% is very, very important part as far as the NAFLD or NAS treatment is concerned. Regarding the pharmacological treatment, the reversal of patient with significant fibrosis and those with the high risk of progression, the emphasis on these subgroup of patients. And here, what we can offer to these patients is pioglitazone, vitamin E, GLP-1 receptor agonist, and some cases SGLT2 inhibitor. So the focus is on non-invasive testing also. So there is recommendation for the going for the screening test, and in these screening tests, the FIB4 is very, very important, which comprises of the index, which contains the platelet count and SGOT-PT. On basis of this, there is a formula, and you can calculate the FIB4 index. And on basis of FIB4 index, you can subdivide your patient into three categories. One is index less than 1.7, another is index more than 2.4, and if the index is more than 2.4, the patient is supposed to be having high risk, and if it is less than 1.7, it is almost the diagnosis is ruled out. The thing is, if you are dealing with the patient who are the intermediate type of this patient you can go for all these non-invasive investigation like ultrasound, and you can also measure the elasticity of the liver with the FibroScan, and on basis of these you can categorize your patient into high risk, low risk, and very high risk. If the patient is having very high risk, you can utilize more than 2 therapy for this subgroup of patient, especially if you are using GLP-1 receptor agonist and pioglitazone. These are the very, very important drug in the patient who has been going for the NAFLD. And don't forget, these patients are also having high risk for the cardiovascular disease, and both the GLP-1 receptor agonist and pioglitazone are very, very important drug for the secondary prevention, and GLP-1 receptor agonist is very important drug for the primary prevention of the disease also. So this becomes a very important, and nowadays an emerging target which is coming into the picture, that is the role of gut microbiota in this regard. And there are many experimental therapy which has been tried in this area to modify the gut microbiota. Overall, multidisciplinary approach is very, very important to deal this patient in the primary care setting, and if required, endocrinological consultation, gastroenterological consultation, and bariatric surgery can be done in this subgroup of patients. So it is open for the discussion. Anybody wants to add anything? His thoughts are always welcome. Yes.
Yeah, sir, a quick reminder of our own indigenous discovery, that is saroglitazole. I think we should not forget that. It is a dual agonist and doing wonderful as far as early stages of NASH are concerned. So I think quite a lot of patients have documented improvement sonographically, FibroScan wise, and LFT wise. They have documented improvement in the liver pathophysiology.
Yeah. That is also a very important drug, and it will
and additionally, the advantage of around 0.4 to 0.5% HbA1c correction in a person with type 2 diabetes.
Yeah. So with this, I hope I have discussed the eighth topic also, that is the oral anti-diabetic agent in case of non-alcoholic fatty liver disease, nowadays known as MFLD, another topic which has been raised. So I think pioglitazone, GLP-1, and the SGLT2 inhibitor are very, very important drug in this area. So coming to the sixth topic, that is the role of statin therapy in old adults. And it has been seen in the trials with the benefit of the statin therapy is also documented in the patient with the primary prevention in the older patient. But this area earlier used to be a controversial because of the side effect of the statin therapy on the muscle mass, and there is risk of fall in the older patient. And many people will argue that this patient has already having a very high atherosclerotic cardiovascular disease risk because of the age itself. So what statin is going to do in terms of the primary prevention? Let this patient be free from the drug, and there was other opinion that no, the patient should be given statin therapy to prolong their life. So it was a controversial area, as there was no trial available in this area. But nowadays, recently, the few things has developed in this area, like the statin therapy in older. Am I audible, sir? Hello? Hello, am I audible?
Yes, you are audible.
Okay. So I thought the internet connection is not there. So statin therapy is very, very important in this area. Particularly, I was talking about what about the adult who are having age more than 75 year, and we are giving the statin for the primary prevention. So according to the 2018 ACC/AHA guideline, which suggests that it is reasonable to initiate the moderate and high dose statin therapy if the patient is already on the statin therapy and not documenting any cardiovascular, not having any side effect like muscle cramps and other thing. It is emphasized that the if the patient has lower risk for the fragility, there is no risk for the polypharmacy, and the life expectancy is good, and the LDL cholesterol is between 70 to 189, these drugs should be continued for the primary prevention. So now what is the concern that because of the statin therapy there can be cognitive abnormality, and as the statin is associated with the statin associated diabetes, and it can increase the chances of the drug interaction with the other drugs, as we all know that the P450 cytochrome is involved in this regarding the drug interaction. So whether we should prescribe this or if we should stop this. So the de-prescribing statin in older adult, particularly who are having their limited life expectancy and having severe fragility, is a complex decision, and it should involve 5M framework. So the importance of the 5M framework is very, very important. The 5M are mind, mobility, medication, multi complexity, and what matter most. So this is the 5M approach, which is the geriatric society is um, mainly doing for the drugs. And if there is decision in favor of the patient, it should be stopped. Otherwise, if all the parameter like the patient is not dementic, the patient can walk, patient is not having issue with the medication, there is no complex interaction, and patient has good quality of life, then in those subgroup of patient we can say that these patients are having good biological life, and statin should be continued in this patient. So de-prescribing or stopping the statin is highly individualized decision, and nowadays it is the shared decision making, and nowadays the plenty of evidence are there that these patient can also have benefit with the statin therapy with the availability of the different trial. So overall, if your patient is having age more than 75 years and having good biological age, you can continue with the therapy and you can start statin in this age group also. So this is a new change. I think it was worth emphasizing on that. Anybody wants to add anything in this area, then their thoughts is welcome. Yes? Any suggestion? You can also type the suggestions in the box also. I am coming to the question 11, that is the renal life cycle trial. The renal life cycle trial is also very, very important, as it deals with the dapagliflozin patient ongoing dialysis and the patient who is having CKD more than stage 4 or 5. So stage 5 patient, what is the role of DAPA in prevention of renal function? So this renal life cycle trial address this issue. So in this subgroup of patient also, the DAPA is now being evaluated for the therapy. So this is also very, very important. And I'm going to the next topic, that is the GLP-1 medication for the type 2 diabetes in obesity. The newer the suggestion shows that since the risk of pancreatitis is associated with the obesity, and the patient are early thought to be having increased risk with the GLP-1. GLP-1 nowadays, it has been shown that even if you are prescribing GLP-1 with type 2 diabetes, it may lower the risk of the acute pancreatitis, as it can resolve many of the risk for the acute pancreatitis.
Which topic number, Dr. Ashutosh?
13.
13, okay. Just mention the topic number also, so I can coordinate the slides.
Okay. Anybody wants to add anything? Coming to the next topic, that is the vegan protein and risk of cancer, obesity, and cardiovascular disease. Dr. Pallavi will say something on this. Vegan protein.
So good evening, everyone. It is seen that vegan protein actually increases the level of glucagon, and due to this can reduce the risk of cancer, obesity, and cardiovascular disease. So it is seen that when glucagon level increases, it causes decrease in cardiovascular risk by decreasing acute heart failure risk, decreasing, and it is antiarrhythmic, and it also reduces major adverse cardiovascular event.
What is the mechanism of action you see in if the patient is being prescribed with the vegan protein, how it is going to help in the obesity, cancer, and cardiovascular disease? That is the main point which we are going to cover in this. So as the vegan protein contain less amount of essential amino acid as compared to the animal origin protein, this is the mechanism which may lead to the gluconeogenesis and protein catabolism, and it will eventually lead to increased glucagon level, and as the weight loss will occur, it will protect from the obesity, and it will protect from the cardiovascular disease, as it will act on the different arms which are cardioprotective, like it increases the acute decompensated, it decreases the chance of acute decompensated heart failure, it will increase the coronary circulation, it will have a positive effect on the ventricular remodeling, and it will be a very beneficial effect on the LA diameter. So now the new things are coming up into the glucagon picture, and I think Dr. Pallavi will add on to it. I think there are some differences between heart failure with reduced ejection fraction and heart failure with preserved ejection fraction. The mechanism of action of the glucagon differing in those two identity. Over to Dr. Pallavi to emphasize upon the beneficial effect of the glucagon in heart failure with preserved ejection fraction. I think in heart failure with preserved ejection fraction, what happens is the increased glucagon level will reduce the epicardial fat, and because of this reduction in epicardial fat and the LA diameter, eventually this will have a beneficial effect. That's why the SGLT2 inhibitors are very good drugs in patient with heart failure with preserved ejection fraction. And in case of heart failure with reduced ejection fraction, actually the ventricular remodeling, which is mainly affected, and end systolic diameter is eventually going to decrease. So I hope this will solve the query. And anything you want to add, Dr. Pallavi?
Yes, actually, this glucagon molecule is more helpful in acute decompensation of heart failure than chronic heart failure.
That's what I said.
Yes, and it is also very good anti-arrhythmic. It has a very good anti-arrhythmic effect also.
Yeah.
So these two properties are very important for glucagon.
Yes, yes. This point is very, very important, as this will improve the impulses from the SN node to AV node. These are very, very important drugs to reduce the arrhythmias. So the chances of post-MI arrhythmia is decreased in this subgroup of patients. So coming to the next topic, that is the role of semaglutide in CKD patient, and the GLP-1 receptor agonist, they are very, very good drug for the patient who are having CKD and diabetes, as we can use this drug up to the eGFR 15, and these patients are having more chances of hypoglycemia. So I have to mention the topic number. Yes. So it is 12. The topic number 12.
Okay.
Go to the topic number 12. Yeah, the effect of the semaglutide glutide on chronic kidney disease in patient with type 2 diabetes. So what happens with the help of the, so these are few things which are already there. So we can, there are a few questions in the chat box, and we'll like to have discussion on that after finishing this topic number 12. So GLP are receptor agonists. They are very important drug which can be used up to the eGFR 15. And as this patient patient will have less hypoglycemia, if you are using GLP-1 receptor agonist in CKD patient, the drug becomes further important. And if it reduces the weight, it reduces the waist circumference, it reduces the perinephric fat also, which is the fatty kidney. So this is one thing which is now gaining importance in the area of cardiometabolic disease and CKD patients. So GLP-1 receptor agonists are becoming a very promising agent in type 2 diabetes patients. So this is all theory. What about the evidence? The evidence comes from the FLOW trial, which was a landmark double-blind randomized controlled trial in which the semaglutide once weekly 1 milligram in type 2 diabetes patient with the CKD patient, and it has caused 24% reduction in the cardiovascular disease. And this trial demonstrated that there is slow decline of eGFR in this subgroup of patient, and there is also reduction in albuminuria. Apart from this, there is also trials from the real world evidence, and safety and tolerability is very good. So nowadays the renal protection of the GLP-1 receptor agonist is also very, very important. And in summary, we can say that it is from the real world evidence and from the trial, the semaglutide is very effective in and generally well tolerated in type 2 diabetes with the CKD patient up to the eGFR 15, and it can be used in patient and if the patient is not having any deterioration of renal function like AKI, and if the patient is not having nausea and vomiting also in this subgroup of patient, apart from this subgroup of patient, in other patient this drug can be used. So I can see question from the VK Jagnani. Jagnani sir, are you listening? Hello.
Yes, I am here.
Yeah. So you want to add anything, or you want to say something?
I have some confusion. I want you to answer them.
Yeah. Go ahead.
I put in the chat box.
Okay.
I'll just open the chat box. My first question is, any statins particularly that should be used which can cause lesser side effects like muscle cramps or anything?
Yeah. So that is also a very good question. And regarding this, I think the pitavastatin is thought to be one of the statin which is milder, and rosuvastatin is one drug which is having more muscle related side effect. So if you are using this drug, you can go for either pitavastatin or atorvastatin, and what you can do is you can use the intermittent dosing also of the statin therapy in this subgroup of patient to have lesser muscle related side effects. like twice weekly or alternate day therapy of these rosuvastatin or the atorvastatin, it can be used to reduce the muscular side effect. What we are doing in our clinical practice, suppose somebody is having muscle cramps and the muscle related side effect with the high dose statin therapy, we are giving the intermittent therapy, and later on the patient tolerates, and then we monitor the things, and if everything is fine, then we can increase the dose to the daily therapy. Most of the time you can give vitamin D along with the statin therapy, and it will alleviate the symptoms. And most of the time the side effects are temporary, and it never go more than 6 months time. Anything else?
Another thing, when EMPA and DAPA were costly, we were using Remo.
Yeah.
So if the sugars are controlled on Remo, should we change them to DAPA EMPA, or because we have better data with DAPA EMPA in comparison to Remo?
Yeah. Definitely, we should go for the evidence-based medicine, and if the cost is equal nowadays, then we should switch our patient to the better therapy and better evidence-based practice.
Where do you find oral SEMA in comparison to injectable GLP-1?
Yeah, I think the injectable GLP-1 is better than oral semaglutide.
Exactly. I fully agree with you.
Yes.
I fully agree with you. It
And
is very much light molecule.
Generic versions are also available with the injectable liraglutide, which is now off patent. So we can give this benefit to our patient, and particularly the patient, particularly who are on basal bolus regime. Now we can combine the basal insulin along with this GLP-1 receptor agonist to have a better effect and better glycemic.
I fully agree with you on this.
So
an interesting thing, we just talked about vegan proteins that cause increase in glucagon, and then they have benefit on terms of CV diseases decrease.
Yeah.
Now DPP-4 inhibitors are glucagon inhibitors.
Yeah.
Yes.
So this then they should increase the risk of cardiovascular disorders?
No, it's not like that. Everything is not depending on only glucagon. What we have to look into this regard, that DPP-4 inhibitors are the molecule which are inhibiting the DPP-4. Not only the glucagon is one thing which has been degraded in this thing, but there are other molecules also which has been affected by DPP-4 inhibitor, and they have some immunological property and anti-inflammatory property as well as anti-fibrotic property as well. Like you can see in case of linagliptin, there is anti-fibrotic property, and there is different effect which are occurring on the kidney. So linagliptin is more kidney protective as compared to the other DPP-4 inhibitor. Likewise, for the sitagliptin, it has been shown that they have some better endothelial property, and their effect on endothelial dysfunction is demonstrated more. So these type of differences are there. And in case of the vildagliptin, the HbA1c reduction is more sustained and the longer as compared to the other one. So what I am saying is, the DPP-4 inhibitor, all DPP-4 inhibitors are not same. Only glucagon is not going to solve the problem that you can interpret that glucagon is increased, and now you can say that this is cardioprotective, and glucagon is decreased, and now it will be decremental. Other factors also plays a role. The thing is, the most important factor which determines the cardiovascular mortality is what happens to the weight. If DPP-4 inhibitor are able to reduce the weight, then in that scenario, most of the time, I can expect that they will have a beneficial effect on CV, but unfortunately, they don't do. That's why there is no CV reduction. And in case of SGLT2, in case of GLP-1, in case of the vegan diet, in all these things, one thing is common, that is the weight loss. So if the weight loss is there, if the anti-inflammatory property is there, then surely it is going to reduce the cardiovascular mortality.
And of course, I guess the glycemic control is very important when we talk of CV disorders, reduction in CV disorders.
Yeah. The glycemic
And
control is also important.
when we talk of vegan proteins, do we include dairy products or we exclude
No.
dairy products?
No, we exclude dairy products.
We exclude dairy products.
The point is the vegan proteins are the proteins which hardly increases the cholesterol, and it doesn't contain essential amino acids. Most of the essential amino acids are missing. So body will try to accommodate the things with the help of proteolysis, and in this process, gluconeogenesis process will be stimulated. As you know, that the insulin glucagon ratio is going to determine whether there will be protein formation or there will be protein degradation or there will be gluconeogenesis. So once the process is tuned like it is being pushed towards gluconeogenesis or proteolysis, then there will be a weight loss and there will be a beneficial effect, and it will neutralize some of the bad mitogenic effect of insulin. So insulin, the natural antagonist is glucagon. So actually insulin glucagon ratio determines what happens to the most of the metabolism.
Just by the way, when we talk of vegan, do we include the pulses or should we not include
So
the
pulses
pulses?
are included.
Pulses.
Pulses are soya, pulses are included in that.
So pulses do not contain the essential amino acids.
No. Most of the pulses doesn't contain unless until you include the seeds. If you include seeds, most of the essential amino acid will be covered. Like if you are planning a vegan diet with plenty amount of essential amino acid, try to include more number of seeds like chia seeds, the alsi, and other things would be included.
This was new to me.
Yeah. So
This
seeds,
was new to me. I didn't know that pulses don't include amino acids.
it contains,
No,
but
sorry, essential amino acids.
yeah, essential amino acid. If you look at the spectrum, some of the essential amino acids are missing, particularly
Okay.
the R and H. The R and H and other proteins are missing, but if you include more number of seeds, so if the seeds are included, then essential amino acid will be there.
We have question from Dr. Yasmin
Yeah.
about opinion on bempedoic acid.
Yeah, you like to answer this, sir? Question? What is your opinion on bempedoic acid?
They promote it to be decreasing in LDL, but I am not very confident, to be very frank. The uses which I have done,
According to the data which has been shown from
data suggests
yeah,
data suggests that bempedoic acid decreases LDL significantly, but practically, I'm yet to see the results.
Yeah. The thing is, according to the New England Journal Medical Trial, in the statin intolerant patient where bempedoic acid was
Exactly.
used, so in this subgroup of patient, we have some amount of data in favor of bempedoic acid, but still we need more data and other.
We need more data on this. There is another question from Dr. Yasmin about myopathy when GLP-1 agonist is used with statin.
I don't see any reason of GLP-1 increasing the chances of myopathy in the statin use. I will research on this area and I will post the answer in the faculty group. But I'm not aware of any thing which is exaggerating the myopathy if you are using GLP-1 receptor agonist along with the statin therapy.
Nowadays,
Dr. Jagnani, hello.
yes,
Good
ma'am.
evening, Dr. Jagnani.
Yes, ma'am. Namaskar.
Namaskar. So, Dr. Saab, what is your choices other than statin when LDL is not controlled? Then what other drugs you are choosing to decrease the LDL level?
Madam,
Because I am actually utilizing this bempedoic acid.
I have put almost 100 patients on bempedoic acid along with a statin, right? But
Okay.
the data and the practically patient which we are seeing,
Yes.
that matlab, the scientific data which we are getting from the research and our patients, that data doesn't match. That is what I want to say. Matlab, I feel that it is a little overhyped molecule. This is
Sir,
what I feel.
sir, I wanted to say that I don't know, but I see few prescriptions of bempedoic acid, and the reason given of choosing this molecule is that the incidence of myopathy with bempedoic acid is very less. I am not clear about it. I have never read anything like that.
No, I am talking only about LDL decrease.
But they say they are
Myopathy, myopathy, I agree.
yeah. That is what is the reason they give when they choose bempedoic acid. They say that
My,
both
In this
of them,
regard,
statin and LDL reduction with statin or bempedoic acid, both is equally good. But bempedoic acid causes less myopathy, so might
that,
as well choose that.
that I agree that myopathy is lesser with bempedoic acid. No confusion about that. But LDL reduction is
Is not up to
not
first
not up
thing,
to our
first thing,
expectation.
definitely.
yeah,
definitely.
first thing I just want to emphasize is statin-induced myopathy is very uncommon in our area.
Exactly.
Yes.
I
So
do agree with you.
Agreed,
the
agreed.
diagnosis is overhyped, and any kind of muscle pain and arthralgia, myalgia, these are should not be interpreted as myopathy.
Definitely,
It
sir.
should
Exactly.
be
I agree.
evaluated, and the benefit of drugs should be given to the patient, and we should try to use more and more patient with the moderate to high dose of the statin therapy. If your
I
patient is having any kind of myalgia, arthralgia, counsel your patient, give vitamin D, utilize intermittent therapy, gradually increase the dose over a period of next 6 months. You will see that 90% of your patient is going to tolerate high dose statin. There is no problem in that.
agree with you.
So we should
Dr.
go
Ashutosh,
with the evidence-based
But-
medicine and utilize it.
But in spite of highest dose of statin, sometimes
Yeah,
LDL
if
control
your
is very
target is
difficult.
not made, then
I
I think estamide should be added.
Yes.
And if still the target is not met, then bempedoic acid can also be utilized, and try to counsel your patient regarding the cost of the therapy, and you can go for the PCSK9 also. Dr. Avjit is also joined. Welcome, Dr. Avjit.
thank you,
Nice
Dr.
to see you.
Yeah, nice to see all of you again. Thank
Yeah,
you. I have a small
your
comment to make.
opinion about this molecule, sir. Yeah.
Yeah, see, there is a lot of difference between this muscle pain and myopathy.
Yeah.
Any kind of muscle pain is not myopathy unless it is accompanied by the elevation of the CPK enzyme.
Yes.
Most of these people who complain of muscle pain must have read something in the internet and they are very scared. So they complain of muscle pain. But once you test the blood, you find that the CPK is normal. So you might as well continue.
Yeah,
Yeah.
that is true, very true. And the cardiovascular benefit, I think, is more with statin. So we don't know about bempedoic acid, how much events it can prevent. Like statin, once it used to be described as beneficial for so many things, antioxidant, this, that. So I was not sure about bempedoic acid. That's why I wanted to know what is the.
Ma'am, I entirely agree with you. You know, statins have got a robust, a good track record for
Yeah, yeah,
over 25 years.
yeah,
And bempedoic acid can hardly be a match with that.
yeah. Thank you so much, sir, for this discussion. It was really enlightening. Thank you.
Thank you.
So, moving to the next thing about the, I think we have covered most of the thing, and
So one more question I have, whether like if we are considering for weight loss only, so what is the position of oral GLP-1 analog? Is it better than injection tirzepatide? Because once we have discussion over here, we have said that we have learned that injection tirzepatide is a better option rather than oral GLP-1 analog.
if you are talking of a weight loss, the injectable GLP-1 receptor agonists are doing far better as compared to the the oral GLP-1 receptor agonist, if you are talking about the injectable semaglutide and oral semaglutide. But if you see the molecule which are having injectable GLP-1 receptor agonist having larger molecule, like if you are talking about the dulaglutide having a very larger structure, and if you are using dulaglutide for the weight loss, then there will be hardly any weight loss because of its larger molecular weight. It will not cross the blood-brain barrier, and hypothalamic effect of this GLP-1 anti-inflammatory property will be less. That's why the dulaglutide is different than the smaller molecule like liraglutide and the semaglutide. And if you look at the derived GLP-1 like the exenatide and other molecules, they will cause lots of GI problem, and they have a very small structure, and they will have a hypothalamic effect, but their side effects are more. That's why they are not a very good option. So we are left only with the two molecules, that is the liraglutide and the semaglutide. Till date, the both liraglutide and semaglutide injectable are doing better than oral semaglutide therapy. But there is a debate regarding the dose of oral semaglutide. Like if you are using 50 milligram, I'm repeating it, 50 milligram of oral semaglutide, then it will cause weight loss. And trials are on regarding this oral semaglutide 50 milligram. So in future, we will see what is the difference between the GLP-1 injectable and oral. One very important point we should emphasize at this point of time is the GLP-1 which has been given orally and absorbed into the splanchnic circulation. It is going into the liver first and then into the brain. While if you are injecting GLP-1 receptor agonist in the systemic circulation, their level in the brain will be different. So a molecule which is going to the liver and then going to the brain, a molecule which is directly going into the brain, the injectable therapy has got better effect on the brain as compared to the oral one. That's why the pronounced weight loss is there with the injection.
Sir, but many studies are showing that injection tirzepatide is very good for weight loss.
Yeah. Injection tirzepatide is even better than GLP-1 receptor agonist,
Yeah,
because it is a triagonist. It contains GLP-1 receptor agonist. It has a property of glucagon. It has property of GIP also. It is a triagonist. That's why.
So you have any experience of using this molecule for weight loss? Actually, I see very few.
Tirzepatide is a twin protein. It has both GLP-1 and GIP property. There are now triagonists are also coming up, where the glucagon, GIP, and GLP-1 three combinations are there, and they are even better than this molecule.
Yeah. That's all. Thank you, sir. Thank you so much.
So with this, I think we have covered most of the topic. Dr. Abhijit, you want to add anything?
No, nothing. Thank you. Excellent discussion.
Thank you, sir. Nice to see you.
Thank you, sir. Thank you so much.
Thank you. I'm sorry I came back home late. I was stuck up in the hospital.
Nupur, one suggestion, please. We can have a sorting of these topics prior to the meeting, and please keep the time little bit more towards in the evening so that everybody can join.
Yes, absolutely.
Yes, agreed, sir. Agreed.
Yeah. Thank you very much. Thanks for the.
Thank you. Namaskar. Namaskar. Good night, everyone.
Thank you. Good night.
Good evening, sir. Good evening, sir, and good night. Good night.
Good night.
Good night, ma'am. Good night.
Bye bye.
Thank you
Bye.
everyone for joining. Yeah. Thanks. Good night.
Good night. Bye.